So, Dr. Anita, am I audible to you? Am I audible? Can you hear me, Dr. Anita? Am I audible?
डिजाइन करो मंत्री कुर्सी
ऑडियो बंद कर टीवी ऑडियो जा रहा है.
Okay, Dr. Anita, can you hear me? Dr. Pallavi, can you hear me? Pallavi, can you hear me?
विधानसभा सबका
Yes. Very clear.
Okay. Good evening, everyone. Thank you for all those who have joined us. Republic Day to everyone. So, this is the first of the series of the Golden Jubilee celebrations of our hospital. We are going to complete 50 years since its inception. And my father has always been, very much interested and has trained many people when he was here in Muzaffarpur in cataract surgery, in IOL implantation, and then phacoemulsification. So, let's start any intraocular surgery. Any intraocular surgery, the foremost thing is we need to prevent infection, and it will be the first here you can see that 10% povidone iodine is being placed in the eye as well as all around the eye so as to have a good sepsis. It should be done from inside out. Once you have done that, then your double drape is placed, and then you just dry this part of the eye because you want the adhesive drape to stick properly to the eye. Once it's dry, you ask the patient to open the eye. Your assistant holds the lids apart, and then you can use this adhesive drape. What this maneuver does is that not only opens the eye, keeps the eyelashes away from the surgical field. You just press slightly all around, and using scissors, you can simply cut this. Careful that you do not injure the corneal epithelium. And this is done. So now the patient is ready for surgery. A few drops of povidone iodine again instilled in the eye and washed immediately. And then you make your cystotome and bend it. Make sure to wash the sac very well because betadine is toxic to the endothelium, and you must squeeze out all the betadine that is there, but so that it doesn't go inside the eye. Just press it a little bit. Okay. So I'll stop this here, and so we will begin with a very simple case of phacoemulsification. This is a routine phacoemulsification being done. Using an MVR, I use an MVR blade to make the. I'll just go back. Start it again. So an MVR blade is used. It's a tight incision on both sides of the eye, circle away from the limbus. So you can use tooth forceps to stabilize the eye from the opposite end. Now comes the introduction of trypan blue, which is always done by me under air. That allows you to not only protect the corneal endothelium, but also the concentration of the dye that you use in an air-filled eye gives you better stain. And then you take your viscoelastic, go to the end, opposite end of the eye, and then once you've made your groove, so I will show this again. What I did was that I made a groove in the area of where the incision is going to be placed. And then within that groove, I went inside the cornea and then just the keratome go inside and slightly enlarge the incision. This is a 2.2 keratome. The incision has been enlarged to a 2.4. This is a Gaurav Luthra marker. Just press it upon the cornea to give you somewhat approximation of the rhexis that you're going to do. So one must try and measure this every time so as to be very consistent with the size of the rhexis. Then what we do is that we raise a flap of the anterior capsule, then putting the flap flat on the surface of the eye of the lens, and following the mark that we have made on the cornea, we make a circular rhexis. So this is most important step in phacoemulsification. You must have a central, circular, and a complete rhexis. Then comes the hydro procedure. Very small aliquots of BSS are injected in multiple quadrants. The nucleus is pressed and rocked so as to push whatever fluid has gone behind the nucleus for it to come out. And once you do this in multiple quadrants, usually the nucleus becomes free. You can also, at this point of time, rotate the nucleus. But since I saw that it was rocking well, I haven't done that particular step. Then with the infusion on, one goes inside the eye. And now you must be able to, let me go back.
Yes.
The patient is slightly uncooperative. So you embed the nicotine, it goes inside the substance of the nucleus, and you do a vertical chop and horizontal separation. So you not only rotate the eye, you not only rotate the nucleus, but also you're making multiple chops and dividing the nucleus into multiple fragments. You can see here that I am making multiple eyes of the nucleus. Now, once I've done that, now each pie is brought up and further chopped into a smaller piece and then emulsified. So if you have done a chop, normally your eyes will come out very easily. You can see here that all these fragments are coming out very well. So depending upon whichever machine that you have, machine can be tuned to give you various powers. Like this nucleus wasn't very hard, so the amount of phaco energy that one is going to use is going to be lesser. So once you've removed the nucleus, you can also remove whatever part of the epinucleus that is there. And if the hydro procedure has been done well, sometimes even the cortex can be aspirated. This is not recommended for everyone and should not be done in beginners at all, because you may need to catch the posterior capsule while you're doing this. And what you just saw was that I always make it a point to inject viscoelastic from the opposite eye opposite side port, so as to always keep the anterior chamber formed, and this helps in you know preventing the trampoline effect. The eye is going to become soft, and then you go in, and again when you come out again, the eye is going to become soft. That is going to happen multiple times. So one must try and prevent the trampoline effect. So okay, so what I would like to show is that this is a bimanual irrigation aspiration. So the one is irrigating and the other is aspirating. You go inside, catch the end of the cortex, bring it to the center, and then aspirate. Do not try and aspirate before you have brought it to the center. You just nudge this cortex a little bit and allow it to come to the center. Now, just I would like to stop, pause. Now, see the location of this irrigation. This irrigation is just behind this aspiration. What this irrigation is doing is it is going to prevent the posterior capsule from jumping up into the irrigation, and it will allow you to bring this cortex into the aspirating port very easily. So when some surgeons say that your irrigation should always remain steady. No, the irrigation is also as active as the aspiration. So you should bring the irrigation as close to the aspiration as possible so as to prevent the AC from being caught. So you can see that irrigation is always closer to the aspiration. Again, I'm going to come out, and before I bring the irrigation out, I'm going to inject viscoelastic once again into the anterior chamber. So every time that I do this, the eye is always formed. This surgery is being done under topical anesthesia, so the I'm putting uh, lignocaine just before injecting the intraocular lens. Try and always load the implant yourself. Do not rely on your staff or your assistant to load the implant. You are seeing under microscope, but most usually the assistant is not seeing under microscope, and he may uh, catch a haptic in the cartridge, and you may not know that the cartridge has been the lens has not been loaded properly. Okay. So what you are seeing in my left hand is this is my left hand using a spatula, and this spatula is 1 millimeter in thickness. It fits snugly into the side. You can see that it is fitting into the entire side port. What this spatula does is it provides the counter action and also the stability of the eye while you are doing any procedure inside. This is a wound-assisted implantation of the intraocular lens. Must be within most of the incision. If you are slightly not properly within, then the implant will open outside. So when you do this maneuver, make sure that the top of the cartridge is maximally inside the tunnel of the incision. Okay. So again, you must see how this is done slowly. Leading haptic goes inside the bag, and then the trailing haptic is injected just over the iris. Using the dialer, one just dials the trailing haptic into the bag. Now you can see that the entire lens is within the bag. Then irrigation aspiration, remove whatever viscoelastic that is there. Using the irrigation, one can lift up the edge of the intraocular lens to go behind the intraocular lens and remove whatever viscoelastic is there from behind the lens. This is a very important step that one must learn, because when one does toric intraocular lens implantation, no amount of viscoelastic should be there behind the implant, so that it doesn't rotate later on. And as such also, if you leave behind viscoelastic behind the intraocular lens, the next day you may have increase in intraocular pressure and a hazy cornea. Once you've done this, remove the viscoelastic, then the hydro stitch, as Dr. Uh, you're basically hydrating the wounds so as to make the eye tight and leak proof. Dr. Harshul calls this as a hydro stitch. And then just gently nudging the intraocular lens towards the posterior capsule, little bit of hydro to the wound, and then checking the globe for its uh, intraocular pressure. So what you just saw was just before I injected. Let me just show it again. Here, I have loosened up the speculum just before I have injected intracameral moxifloxacin. Why have I done this? If the eye is the pressure is on the higher side, whatever moxifloxacin that you inject will tend to come out. So you just make the speculum slightly loose so that the globe is not very tight, and it will allow the moxifloxacin to stay within the eye. Again, you check, and then you come out. Normally, I use an antibiotic ointment to that is placed in the cul-de-sac. So now, if there are any questions from anyone, if anybody wishes to ask any question, and if all you want a particular surgery to be demonstrated, please message me on WhatsApp so that I can also take up whichever surgeries that you would want to see. But it cannot be very lengthy, so that because more than 1 hour or more than 1.5 hours, it's very difficult for everyone to find the time. So please do let me know if you find that anything I may have missed out on. And thank you for joining today, and wishing everyone a good night. Thank you.